Just not to confuse. Yes. When it's done. Okay. Okay.
Good morning. It's now 8 o'clock and it's time to start our exciting Abstract 7 session in pancreatitis. So aloha and welcome to the final day. We have lined up really exciting presentation and we are hoping for thought-provoking discussions. Just a quick note from the housekeeping, you will have accessible all the presentations if you have missed anything up to 90 days from now through our app. And of course, just to remind us, it is truly a historic joint meeting that has been an incredible opportunity for collaboration and innovation. So together we are advancing the understanding and treatment of pancreatic diseases, and your participation is, of course, most valuable. So thank you for being a part of this remarkable journey. Let's continue to work together to make a lasting impact. So with this, we can start the session. My name is Slavica Tujarova. I'm coming from UCLA. And another chair is...
And my name is Li Kai. I'm come from Chongqing General Hospital.
And we have a pleasure to introduce the first speaker. That is Dr. Temel Turkish, with what have we learned from a decade of research on MRI of chronic pancreatitis.
Thank you very much
Dr.
for the kind
Turkish.
presentation, and good morning, everybody. Thank you for showing up on day 4, 8 a.m. I will be talking about on the snapshots of multiple abstracts or papers instead of just one. And I will try to do this within just 7 minutes. And if there's a take-home message that you should have from this talk is going to be that concepts of chronic pancreatitis imaging have significantly changed and improved within the last decade. And I want to give you just a snapshot of it. So there are many, like I said, this is not just a single paper, many papers, but all the, basically the concepts that came out of these papers, I will summarize them within just 7 points. And the first thing is that MRI parenchymal features have better correlation with histopathology than the ductal features by MRCP. There are several papers that I could present, but I don't have time for that. I'm just going to present just an example paper for you for this. We have to correlate our imaging findings with histopathology. And on the left, you are seeing the patient with a mild chronic pancreatitis showing fibrosis, acinar cells. And in the lower side, you can see also severe chronic pancreatitis with almost half of the gland is replaced with fibrosis. And there are also liposomes within the gland as well. So these changes, how do they reflect into on the MRI of the parenchyma, and how does it reflect to the ductal changes? That's the correlation that we looked into. And basically, the MRI signal is decreasing as the severity of the chronic pancreatitis increases, and the correlation is higher than the same correlation seen with the ductal changes with the fibrosis. Another paper from Minnesota looked into the TPIAT patients, and they took the whole gland and correlated with the MRI findings, and their correlation of the MRI findings with the parenchymal fibrosis grading was similar to ours, 0.44. This is the highest correlation that we know of any biomarker with the pancreatic fibrosis. There are several papers that I will touch base at 11:30 talk. I have more time, 15 minutes in that one. This one, the second one is the MR parenchymal features can detect chronic pancreatitis earlier than the MRCP. I'm going to give you one example paper again. There are several we had several recurrent acute pancreatitis patients at IU, but their MRCP was normal. And therefore, the endoscopist, as the last choice, they go and do the endoscopic pancreatic function test, collect the bicarbonate, and they determine whether the patient has exocrine dysfunction or not. We looked at these patients' MRIs and correlated the T1 signal with the bicarbonate level. The green dots represent the MRI signal on patients with normal bicarbonate, and the red dots represent the low bicarbonate. As you can see, there is no MR signal that is, it really well correlates with the low bicarbonate levels, and there was like almost no red signal over the 1.3, which is kind of a threshold that we use. So this study and other studies reflect the fact that the MRI ductal changes happen after the parenchymal changes. The parenchymal changes comes first, and the ductal changes are sort of a complication of the fibrosis and active inflammation going on in the parenchyma. So why not to use the parenchyma? So there is definitely a months or maybe years of time that the ductal changes do not happen, but the disease is happening. MRI signal correlates with severity of the chronic pancreatitis. I'm sure you all know the PROCEED study, which has been going on for 9.5, almost 10 years now. PIs are Dr. Yadav and Dr. Conwell. In this study, we have several thousands of CTs and MRIs. We did a cross-sectional correlation of the severity with 820 MRIs in these patients. And there was a nice linear correlation with the severity of the disease and the MR signal. We also made a mechanistic stages of chronic pancreatitis, which separated the severity into 7 categories. And the T1 signal was again going lower with the 1.2 threshold. So T1 signal, I'm convinced that it correlates with the severity of the disease. Progression of chronic pancreatitis is better seen MRI than the MRCP. This was done by our European colleagues, and they followed the chronic pancreatitis for 4 years. They looked at the pancreatic volume, diffusion-weighted imaging, fat signal fraction, and main pancreatic duct diameter. Their findings show that the pancreas volume has decreased in 4 years, pancreatic fat has increased, and MR diffusion has decreased, but the ducts did not change. So they also agreed that the morphologic progression of chronic pancreatitis is easier to identify on the parenchyma than the ducts. In addition to that, there is also discordance of Cambridge grading by MRCP compared to the ERCP. As you know, the Cambridge was published in 1984 using ERCP. But these European colleagues looked into the Cambridge grading by ERCP and MRCP, and the concordance between 2 modalities was only 43%, which is a horrible number. So you really cannot correlate the findings from the ERCP to the MRCP. And the 6th one is better internal observer variability is needed for assessment of the chronic pancreatitis. So this was a study done at 4 US institutions, Ohio State, IU, Mayo Clinic, and Pittsburgh. These were all well-respected abnormal radiologists, looked at the Cambridge grading by CT and MRI, and their kappa scores are not that great, 0.68, 0.56, and even if you combine these two, it's still 0.62. Whereas in the recent, when you look at the MRI parenchymal features, the inter-observer variabilities are like 0.87, significantly better. AVR 0.87, and the scores are also over 0.70. The same radiologist came up with a 0.54 weighted kappa for Cambridge. And the reason for that is probably because using the MRI quantitative features, you are less subjective, more objective when evaluating the parenchyma. Lastly, pancreatic steatosis is evil. And there's not a single talk that I finish before talking about the pancreatic fat. The histopathologic slide on the left is a normal pancreas without any evidence of chronic pancreatitis. There are normal acinar cells, ducts, and islet cells. On the right, you see a lot of fibrosis, which is the orange one, and there's decrease in the acinar cells, and there is a lot of fat within the gland as well. We have a great scientific, very sophisticated tool called MRI. We can detect the fat signal and water signal and measure the ratio of between the two. In addition to that, we can also do AI to measure the visceral and subcutaneous fat volumes, and we need to discuss this correlation better. There is increased fat in the chronic pancreatitis patients. Is there a fat causing the chronic pancreatitis or chronic pancreatitis causing the fat? This is still out in the discussion. And would like to thank NIDDK for their support for these studies that has been going on for 10 years under the CPTPC consortium. Lastly, concepts of chronic pancreatitis of MR imaging have significantly improved. Thank you very much.
Thank you, Dr. Firdaus. We will keep the questions at the end, so thank you very much. We will invite the next speaker, please.
So the next speaker is Mitchell Cooley from University of Wisconsin. And this abstract authored by a Young Investigator Award. Yes, please.
Thank you for the introduction. I apologize, my voice has not been cooperating, so I will do my best to get through this. I'm very excited to share some of this work I've been doing. So pancreatic acinar cell plasticity makes them susceptible to malignant transformation, especially in the context of persistent oncogenic signaling. But of course, it's the same plasticity that allows for recovery and tissue regeneration after injury as well. And since the exocrine pancreas does not contain what we would consider canonical stem cells, in the mature condition, it must rely on the existing differentiated cells to complete this recovery process. And this has been termed palliginosis by Dr. Jason Mills, who works at Baylor, and he has a number of papers outlining this process, both in pancreas as well as chief cells in the stomach. And I'm just describing this process here. So it requires the utilization of mature differentiated acinar cell to undergo functional downscaling through autophagic means and enter a metaplastic state, so that uprising of things like SOX9 and CK19 to create a progenitor-like intermediate, which is then competent to re-enter the cell cycle and proliferate. And this is how we are regenerating lost tissue after pancreatitis. Of course, those cells then need to redifferentiate into functional acinar cells. And Dr. Mills has identified a number of molecular players that regulate this process. Stage 1 requires downregulation of mTOR and an upregulation of ATF3, which mediates the upregulation of autophagy. Stage 2 requires an upregulation of P53, and that's where we see our acinar to ductal metaplasia markers. And stage 3, we see upregulation of proliferation, and this requires for mTOR to come back into play for cell cycle reentry. And of course, as you might imagine, especially in the context of oncogenic signaling or repeated cycles of palliginosis, you might accumulate new mutations, and that is where we get the possibility for malignant transformation. So understanding this process is very important to understand how the tissue recovers. Of course, pancreatic acinar cells are professional secretory cells. And so for stage 1 palliginosis, we have to dismantle completely the secretory apparatus required for secretion in the cell. That includes not only components of the zymogen granule pathway, but also components of the endolysosomal-derived minor secretory pathway, which we have spent a lot of time studying in Dr. Geiger-Blisky's lab. And this pathway is actually very significant when it comes to regulating digestive enzyme trafficking and secretion. And we see evidence of stage 1 paludinosis in both in vivo and in vitro models of experimental pancreatitis. We see secretory inhibition, loss of secretory polarity, accompanied by basolateral exocytosis, activation of autophagy, as well as downregulation of endolysosomal compartment markers. That includes RAB5, EA1, LAMP1, LAMP2, and our favorite protein, D52. D52, we have a number of papers published about its function, but it is an endolysosomal regulatory protein, and it stimulates exocytosis from the endolysosomal pathway. So on the right there, this is cell surface labeling of the externalized epitope of LAMP1 that occurs after exocytosis. These are non-permeabilized cells. And in the lower panels, these are acinar cells infected with D52 wild type, and you can see a significant upregulation of LAMP1 exocytosis. So it plays a role in the secretory trafficking of that pathway. We can use acinar suspension culture as a model for this paludinosis induced during pancreatitis. It's long been known when you isolate acinar cells, it doesn't take them very long to start to dedifferentiate. And so we see a secretory rundown in panel A, this is amylase secretion over even by 2 hours, all the way out to 16 to 18 hours. There's a loss of digestive enzyme secretion, and this is accompanied by basolateral exocytosis. On panel B, now this is cell surface labeling in the same manner, but we're looking at synaptotagmin 1. This is a granule marker. So you can see in freshly isolated cells on the left, we have nice apical secretion, whereas after 18 hours, we now see a lot of exocytosis occurring along the basolateral membranes. And this is concurrent with loss of markers of differentiation as well as markers of stage 1 paludinosis. So there's a downregulation of spliced XBP1 and MIST1, which drive acinar differentiation. We have a trending decrease in mTOR and a significant increase in ATF3 and the autophagic marker LC3. So this is a great model for looking at paludinosis. During this 18-hour culture, we also get a downregulation of endolysosomal compartments. So D52, RAB5, EA1, LAMP1, LAMP2, just like we see during pancreatitis. Importantly, and I'm not showing the data here, but if we use an adenovirus to maintain expression of spliced XBP1, which drives differentiation, or RAB5, which is a master regulator of the endolysosomal biogenesis, we are able to restore all of these components even after 18-hour culture. And to our surprise, we see the same thing if we overexpress D52. So in panel A, these are, we're comparing freshly isolated acinar cells to those put in 16-hour culture with either a GFP expressing or a wild type D52 expressing adenovirus. And in panel B, you can see we are able to restore those endolysosomal markers, RAB5, EA1, as well as spliced XBP1, and to a smaller extent, MIST1. In C, we are able to restore some of that lost amylase secretion with D52 expression. And in D, we are able to maintain secretory polarity. So again, that cell surface labeling of synaptotagmin 1. You can see that apical secretion is now restored even after 18 hours of culture when we overexpress D52. So this was very exciting to us. So we went ahead and created an acinar-specific tamoxifen-inducible D52 knockout mouse, utilizing the elastase CRE-ERT2 system, and crossed with D52 flox mice. And we administered tamoxifen to these mice at about 8 weeks of age, so we allowed them to fully mature. And here we're looking at tissues collected at 3 weeks post-tamoxifen. And you can see in the bottom row, histologically, the cells, they just look odd. There's these large vacuoles happening, and the morphology just quite isn't there. And in the far right with the toluidine blue staining, you really get a sense of this complete disorganization in these cells at the apical membrane, which is very provocative to us. And to our surprise, we were able to find that D52 knockout actually induces spontaneous palaginosis. So we did not challenge these mice with cerulean or anything. This is just happening after 3 weeks of loss of D52. So there's in panel A, this is a transcriptional marker, so downregulation of PTF1 alpha, upregulation of SOX9 to CK19. Beta-catenin is very largely upregulated, and we also see increase in cyclin D. On panel B, we also see an upregulation of P53, which is necessary for stage 1 palaginosis to occur. And in C, we have we see a significant increase in Ki67 nuclei with loss of D52. This indicates that we are also entering that proliferation stage. So again, this is spontaneous palaginosis once you've dysregulated the endolysosomal trafficking systems. Very interesting. And this last slide. So when you look at 1 year out of tamoxifen, we now also see an upregulation of P21, which is likely downstream of P53. And P21 is necessary to inhibit cell cycle reentry and promote senescence. So suggests that there might be a compensatory mechanism to prevent any further palaginotic cycles with loss of D52. So I'll just skip the summary in the interest of time. So thank you very much for bearing with me. Thank you to my colleagues at the University of Wisconsin-Madison and to Dr. Jason Mills for his insight on our project. And of course, I'm very honored to have received the APAF Young Investigator Award to sponsor this work. Thank you.
Thank you very much, Dr. Cooley. Thank you. I'd like to invite our next speaker, which is Sudipta Dar Choudhury, on the long-term outcomes of splanchnic venous thrombosis in acute pancreatitis, a single-center prospective cohort study. Thank you, Doctor.
Thank you so much for having me here. So we all understand that splanchnic venous thrombosis is an often recognized complication following an following the effect of acute pancreatitis. Can affect all veins, splenic, superior-mesenteric, and portal vein. Most often is detected as an incidental finding, but very rarely we do have occasional complications in the form of hemorrhage, bowel ischemia, and portal hypertension. Now, if we go back to why it happens, there are 3 factors, and this is what we have looked at from our group, and other groups have also looked at it. And early evidence of endothelial dysfunction. When we measured the serum VWF and ADAMTS13 levels in the patients very early on, we saw a very high levels of ADAMTS13 in the VWF levels and low ADAMTS13, suggesting endothelial dysfunction occurs early in acute pancreatitis. In addition to that, when we looked at evidence of hypercoagulability, there were elevated tissue factor levels, protein C levels decreased, thrombin, antithrombin levels increased early on in acute pancreatitis, suggesting that there is endothelial dysfunction and hypercoagulability. And of course, this is a study, of course, from very old studies which have shown that inflammation, around the inflammation, the vessels have stasis, and all of them compounding to the virtuous shroud of having endothelial dysfunction, hypercoagulability, and stasis propagating venous thrombosis. So we went out to do this study to assess the long-term outcomes of splanchnic venous thrombosis in patients with acute pancreatitis, with a key focus on looking at recanalization rates and impact of anticoagulation therapy. This is a prospective follow-up of a cohort of acute pancreatitis with splanchnic venous thrombosis done at a single center, which is a tertiary care referral center in southern India. So the study period over a period of 5 years. We included all patients who had a first episode of acute pancreatitis diagnosed using the revised Atlanta and imaging evidence suggesting of splanchnic venous thrombosis. We excluded young children, pregnant women, patients with chronic or recurrent acute pancreatitis, patients having cirrhosis or malignancy, and any use of anticoagulants for an alternate cause. And we followed them with a follow-up period of at least more than 6 months. So all the comprehensive data was collected, imaging findings. We looked at whether we showed the vessels involved, whether there were co-localized collections, infected collections, anticoagulation, what was given, therapeutic/prophylactic, and severity of pancreatitis, which was graded using the BICEP score and the revised Atlanta. Now, we followed the patients with a minimum follow-up of 6 months, and at each contact, we asked for new onset of symptoms, imaging was revised, and at least patients who had more than 6 months of follow-up were only included in the study. Recanalization was assessed using Doppler ultrasounds by two senior radiologists, and these radiologists were binded to the anticoagulation data. And in patients who had a CT as a part of an ongoing clinical care, we used the CT, and the same two radiologists again revalidated those CT scans to define the extent of and presence of thrombus. And recanalizations was classified as complete, partial, and absent. These are the standard definitions that we used of splanchnic venous thrombosis, which was the presence of an actual thrombus in the vein or the vein appeared compressed or was not fully visualized due to the presence of collaterals. Complete recanalization was defined as full restoration of blood flow through a previously occluded vessel with complete dissolution or removal of the thrombus or obstruction of the Doppler by the Doppler abdomen or a CT abdomen. Partial was defined as more than 50% reduction in the previous thrombosis. Standard statistical methods were used to employed. We did a logistic regression analysis to understand the predictors of splanchnic venous thrombosis recanalization. So in total, we have started off with the 5 years, we had 1,716 patients with pancreatitis, but 376 were excluded because of chronic pancreatitis and 218 because of recurrent acute, leaving us a cohort of 1,112, and they were further excluded because of presence of chronic liver disease, malignancy, being on anticoagulation, and CT was not done in another small group of patients. So of a total of 814 patients that we included in the study, 11% went on to develop splanchnic venous thrombosis. And amongst the 11%, we lost around 9 patients because they did not come back for a follow-up. 10 patients died during the follow-up, and 3 patients refused further scans. So leaving us with a cohort of 70 patients to assess the outcomes of splanchnic venous thrombosis. So these are the baseline characteristics, which was not very different when you look at patients who had recanalization and non-recanalizations. The predominant etiology was alcohol, and most of the patients had moderately severe pancreatitis. There was no difference as the hematocrit levels were concerned or the platelets were concerned at admission between those who recanalized and did not recanalize. Overall, there was no difference in the presence of in the blood sugar levels, the inflammatory scores, the prothrombin time, or the duration of hospital and ICU stay between both the groups. So if you look at the imaging findings, the predominant vessels that we found involved were the retropancreatic splenic vein, but we did have other patients who had combinations of venous involvement, including both retropancreatic splenic vein, portal vein, splenic vein, superior mesenteric vein, and only one patient had an isolated superior mesenteric vein thrombosis. Around 30% of the patients had concomitant infected collections, and a small group had pseudoaneurysms, which are asymptomatic but detected on imaging. So if you look at the percentage of patients who receive anticoagulation, now as per our in our institute, we only offer anticoagulation to patients who have underlying splanchnic superior mesenteric vein or a portal vein thrombosis. So 20% of them received that anticoagulation, and there was no difference in patients who had anticoagulation in terms of recanalization or non-recanalization. There was no difference even when we followed them up for a longer duration. So on a minimal follow of 6 months, spontaneous recanalization was seen in close to 57% of these patients. And we looked at the predictors of recanalization. The only predictor that came forward was the BICEP score. So anyone who had at admission a higher inflammatory score probably had a higher risk of non-recanalization of the venous systems. So just to conclude, retropancreatic splenic vein was the most common. None of the patients experienced symptoms or complications directly related to venous thrombosis. Spontaneous recanalization was seen in 57%, and BICEP score at admission was the only factor significantly associated with non-recanalization of the vein. The limitations were, it was, of course, a single center study, relatively small sample of patients who underwent anticoagulation therapy. But overall, we can conclude from the study that majority of the patients do recanalize after an episode of acute pancreatitis. And severity of pancreatitis probably is a significant predictor for non-recanalization of splenic venous thrombosis. Thank you.
Okay, thank you.
Thank you.
We made a little bit change, and Jala Wang's presentation will be moved to the end. So the next speaker is Zehua Huang from National Nature Science Foundation of China. Welcome.
Good morning, ladies and gentlemen. It's my great honor to make a presentation here. My name is Huang Zehua and come from Shanghai General Hospital in China. My topic is about SI1, ApoE5, and FM2 identified as novel genetic risk factors in recurrent hypertriglyceridemia-associated acute pancreatitis by whole exome sequencing. It will be divided into 5 parts. Firstly, I'd like to begin with the background. Acute pancreatitis AP is an inflammatory disease of the pancreas and with increasing global incidence. Hypertriglyceridemia (HTG) is the second leading cause of AP in China. HTG-AP is characterized by more complications and poor outcomes. HTG is also a predictive factor for recurrent AP-RAP. HTG typically arises from the interplay of genetic and environmental factors. It has been reported that HTG with genetic mutations is associated with RAP. However, genetic predisposition contributing to the risk and the recurrence of AP in the context of HTG still remains unclear. Therefore, this study aims to explore the genetic risk factors of patients with HTG-RAP to further understand the association of genetic variants with the recurrence and severity of HTG-RAP. We designed a 2-phase study. In the discovery cohort, 10 patients with HTG-RAP and 10 patients with HTG with matched HTG and never experienced AP episodes were enrolled and whole exome sequenced. The 39 discovery candidate variants were further genotyped in the validation cohort of 62 HTG-RAP and 53 HTG patients. The demographic and clinical characteristics of the discovery cohort were shown in Table 1. There was no significant difference between the two groups in terms of gender, TG level, BMI, and the prevalence of diabetes, hypertension, and fatty liver. The downstream bioinformatics analysis of the discovery candidate variants were shown in Figure 2. 141 variants were overrepresented in HTG-RAP patients rather than HTG patients, and 20 non-pathogenic variants were excluded based on the genetic prediction software. And the remaining variants were ranked based on p-value, and of which 39 variants were identified to be real mutations to form the candidate list. And the demographic and clinical characteristics of the validation cohort showed no significant difference between these two groups. The 39 variants were further identified in the validation cohort, and the results showed that 3 variants, including SI1, ApoE5, and FM2, were statistically different between these two groups. To further identify the association of the recurrence rate of HTG-RAP and with these 3 variants, the 10 HTG-RAP patients from the discovery cohort and 62 from the validation cohort were included and used in the next subsequent analysis. The results show that the positive groups had a significantly higher median rate of HTG-RAP recurrence than the negative groups. As we know, the recurrence rate of AP was influenced by some other factors besides on genetic risk factors. So we used univariate and multivariable linear regression to further validate. The results show that SI1, ApoE5, and FM2 variants, Ransom score, white blood cell count, local complications, SIRS, ICU admission, and prolonged hospitalization days were positively associated with HTG-RAP recurrence rate. And the multivariable linear regression showed that SI1, ApoE5, and FM2 variants contributed to increased HTG-RAP recurrence rate as an independent risk factors. The severity of AP influenced the disease prognosis. So nextly, we evaluate the clinical phenotypes of AP episodes with these 3 variants. For SI1, the Ransom score, PAS score, the incidence of local complications, SIRS, C-reaction protein, white blood cell, and the platelet to lymphocyte ratio were higher in SI1 positive patients. And as for ApoE5, the APACH2 score, Ransom score, the incidence of local complications and SIRS and the lymphocyte percentage were higher. In FM2 positive patients, APACH2 score, Ransom score, and the incidence of SIRS were higher. We also use the univariate linear and logistic regression to further validate. As for patch 2 score, FM2 variants showed a significant positive correlation with disease severity, while SI1 and APOE5 variants demonstrated no significant difference. All three variants showed a statistically positive association for Ransom score. Regarding biosept score, both APOE5 and FM2 variants were positively linked with severity. None of the variants was found to be a significant determinant for PAS score. As for local complications, SI1 and APOE5 variants were associated with a higher incidence. All three variants showed a strong positive relationship with SIRS, and in terms of other systemic complications, none of them was a significant determinant. Let's turn to the discussion part. SI1 has diverse physiological functions, and interestingly, it's expressed at a higher level in adipose tissue, and it can promote adipocyte differentiation and influence cell cycle regulation. It has been reported that APOE5 was linked with increased TG level, and only one recent study has showed the association between HTG-AP during pregnancy and this specific variant. FM2, also known as FSP1, is determining the position-dependent function of coenzyme Q10, and interestingly, it's also expressed in adipose tissue with a higher level, and it supports glycolysis and transfers electrons for fury. However, there are several limitations in our study. We just focused on exomes and only considered non-synonymous variant for subsequent analysis. And it is relatively a small sample size. In future, we'd like to use a larger cohort to further validate. In conclusion, we used a two-phase study to identify the three variants for SI1, APOE5, and FM2, and demonstrated the potential roles in the recurrence rate and severity of disease. And also, future functional studies are still required in the future. That's all. Thank you for your listening.
Thank you.
Thank you. Now we have a pleasure to invite Dr. Hannah Trivedi on genetic deletion of high mobility group box 1 in pancreatic acinar cells reduces inflammation in mice expressing human PRSS1 PR122H.
Good morning, everyone. Today, I am excited to present our research on genetic deletion of HMGB1 group box 1. HMGB1 in pancreatic acinar cells reduces inflammation in mice expressing human PRSS1 PR122H. And this was done in collaboration with Dr. Bawanji. HMGB1 is a ubiquitous multifunctional protein that can be found in different cellular compartments. In normal condition, HMGB1 is present in the nucleus where it regulates chromatin organization and DNA repair processes. Under cellular condition or tissue damage, it can be released to the extracellular space where it acts as alarmin, promoting inflammation and organ injury in many disorders, including pancreatitis. HMGB1 can be released to the extracellular space in response to different stimuli. It is passively released during cellular necrosis and apoptosis due to loss of the cellular membrane. In conditions like inflammation, HMGB1 can be actively released due to hyperacetylation of its lysine residue, resulting in its release to the extracellular space. As shown in this cartoon, HMGB, well, all alone or in combination with other cytokines, binds to the specific receptor present on the immune cells or fibroblasts, where it activates pro-inflammatory signaling system such as STAT1, 3, and NF-kappa B, among others, and that are involved in the process of fibrogenesis, immunoregulation, and chemotaxis. So, to investigate the participation of HMGB1 in human pancreatitis, our collaborator, Dr. Hu and Dr. Zia, they measured circulating level of HMGB1 in total 133 patients with mild, moderate, severe, and severe acute pancreatitis and repeated acute pancreatitis. And as shown in this bar graph, HMGB1 level were significantly increased in both acute pancreatitis and repeated acute pancreatitis patients within 24 hours of hospitalization. We also reported recently that HMGB1 HMGB2 protein levels are significantly elevated in the saliva of human chronic pancreatic patients. And as you can see in this volcanograph and the bar graph, HMGB2 levels are significantly increased in the chronic patient samples. So based on this data, we concluded that HMGB1 plays role in mechanism of acute and chronic pancreatitis. The aim of our studies are to study the effects of genetic deletion of HMGB1 in mouse acinar cells on pancreas pathobiology and to investigate the role of acinar cell-derived HMGB1 on pancreatic inflammation on a mouse model of severe acute pancreatitis. We used tamoxifen individual acinar cell-specific HMGB1 knockout and HMGB1 flox wild type mice as a control. In wild type mice, HMGB1 is mainly present in the nucleus. In normal condition, compared to wild type mice, HMGB1 mice looks normal and their pancreas morphology are similar to the wild type mice as shown in this H&E image, and the digestive enzymes are also similar in both wild type and knockout mice. So this data suggests that in normal condition, HMGB1 is not essential for the acinar cell biology. We also used R122H mice that overexpress in pancreas a mutant form of human PRSS1, R122H, that is linked with the severe acute and chronic pancreatitis in human. And this mouse model was created by Dr. Bawanji. And as you can see in this panel A, low dose of cerulean that do not cause any pancreatitis in wild type mice induce marked intrapancreatic trypsin activity in wild-type human PRSS1, but especially in the mutant PRSS1. And interestingly, this increased trypsin activity was similar in mutant PRSS1 at 7-hour and 24-hour after the first cerulean injection. Importantly, this mutant mice displays severe acute pancreatitis even at the low dose of the cerulean with the extensive inflammatory cell infiltration in the pancreas, as you can see in the H&E images. Inflammatory cell infiltration in mutant mice especially exacerbated and persistent even after 2 episodes of cerulean pancreatitis, and that leads to impaired pancreas recovery. The data is not shown here. Importantly, intrapancreatic level of HMGB1 was similar in both wild type and mutant PRSS1 mice after cerulean pancreatitis. But HMGB1 was hyperacetylated in the mutant mice during acute pancreatitis, and moreover, HMGB1 nuclear staining in the acinar cells was greatly reduced in mutant PRSS1 during cerulean acute pancreatitis, but not in the wild type mice, as you can see in this picture and the bar graph. We consistently we also found that acinar cells isolated from mutant PRSS1 mice treated with low dose of CCK8 release high HMGB1 level as compared to the wild type mice. Next, we study to determine the role of HMGB1 deletion in wild type mice that express normal normal mice trypsinogen. We deleted HMGB1 in wild type mice, and we found that HMGB1 deletion does not cause any acute pancreatitis in both wild type and knockout mice. And as shown in the figure A to C, cerulean-induced pancreatitis was mild in both HMGB1 wild type and knockout mice, and histological quantification using QPAS shows that there was similar change in the necrosis cell and the inflammatory cells. Moreover, we did not observe any significant change in the pancreatic edema, blood amylase level, and pancreatic trypsin activity in both genotype. Next, we examine the acute pancreatic feature of mutant PRSS1 mice with and without HMGB deletion, and as shown in the panel A and B, cerulean-induced pancreatitis did not change in the necrotic cells, but there was significant change in the decrease in the immune cell infiltration in HMGB1 knockout mutant PRSS1 mice, And also we observed significant decrease in the pancreatic edema in HMGB1 knockout mutant PRSS1 mice, but we did not see any difference in the intrapancreatic trypsin activity. Based on this data, we conclude that mutant PRSS1 mice that display severe pancreatitis, damage to the acinar cell leads to the increased intrapancreatic trypsin activity and concomitant active release of the HMGB1. This into the extracellular space and blood system. This release HMGB1, they increase the inflammatory response and they bind to the receptor present on the immune cell or parenchymal cells, and they can exaggerate the inflammatory response and cause pancreatitis. In this scenario, preventing HMGB1 release or blocking HMGB1 inflammatory response may result in prevention of the acute pancreatitis. Finally, I would like to thank our collaborator and funding agency. Thank you.
Thank you.
Okay. The next speaker is Dr. Samuel Han from NIH, and he will talk about something about the secondhand smoking in pancreatitis.
Thanks so much for that kind introduction. Yeah, it's a pleasure today to be talking to you about secondhand smoking, our results from the PROCEED study. Okay, so as many of you know, smoking is an independent risk factor for pancreatitis, contributing to both disease pathogenesis and disease progression. And the mechanism by which smoking damages the pancreas is multifactorial, and a lot more research is needed in this area. And within chronic pancreatitis, we know that smoking is also associated with complications of the disease, including calcifications, pancreatic atrophy, diabetes, and exocrine pancreatic insufficiency. While there are a number of studies regarding the association of smoking with pancreatitis, there are really limited data regarding the association of secondhand smoking or passive smoking with pancreatitis. So the aim of this study was to utilize the PROCEED cohort to assess the impact of secondhand smoking, which we'll refer here on out as passive smoking exposure across the pancreatitis spectrum. So PROCEED, as many of you know, is a multi-center prospective cohort longitudinal study in the US that's funded by the NIH and is part of the Chronic Pancreatitis, Diabetes, and Pancreatic Cancer Consortium, or CPDPC, and includes participants with a variety of pancreatic diseases, including acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis. And it also includes healthy controls without pancreatic diseases as well. And upon enrollment, participants complete detailed case report forms that detail data regarding their own individual smoking history, passive smoking history, as well as etiologic risk factors and assessments of pain and quality of life. So this study was a cross-sectional analysis of the baseline data collected at enrollment from adult participants in PROCEED. For this study, we limited participants to those within the 3 pancreatitis subgroups: acute pancreatitis, recurrent acute pancreatitis, and definite chronic pancreatitis. And we also further categorized individual smoking history as never smokers, less than 20-pack-year history, and greater than 20-pack-year history. So in total, we included 1,369 participants with chronic pancreatitis, accounting for the largest subgroup. And the proportion of current smokers we found to be highest in the chronic pancreatitis subgroup. So over a third of chronic pancreatitis participants were actively smoking at the time of enrollment, which was higher than those with a recurrent acute pancreatitis and acute pancreatitis. And then categorizing patients by the lifetime smoking exposure, so breaking it down by those with greater than 20-pack-year history, you can see that a third of chronic pancreatitis participants had a greater than 20-pack-year history, which is significantly higher than those with recurrent acute pancreatitis or acute pancreatitis. So this figure depicts individual smoking history, and I want to highlight on the left, that's the chronic pancreatitis subgroup. The orange represents those with a greater than 20-pack-year history. So you can see that essentially half of former and current smokers with chronic pancreatitis have a greater than 20-pack-year history. This is significantly higher than the proportion of heavy smokers that you see with the current acute pancreatitis in the middle and acute pancreatitis subgroups on the right. So in terms of our passive smoking data, 62.9% of participants in the entire cohort reported passive smoking exposure, which was defined as living with someone who smoked regularly for greater than a year. And the median duration of passive smoking exposure was highest in current smokers at 20 years, with a median of 18 years in both never smokers and former smokers. This figure depicts the proportion of passive smoking exposure, which you can see in the pink. So again, I want to highlight the leftmost section, so you can see in chronic pancreatitis subgroup among never smokers, so people who report no history of individual smoking, half of them report a passive smoking exposure history. And this is actually quite similar across the board. So again, with patients in recurrent acute pancreatitis and acute pancreatitis among never smokers, essentially half of them actually have passive smoking exposure. So as you just saw, a significantly greater proportion of participants with chronic pancreatitis have smoking exposure than participants with acute pancreatitis or recurrent acute pancreatitis, with over 2/3 of chronic pancreatitis participants having passive smoking exposure. They also had a longer passive smoking exposure duration with a mean of 21 years compared to a mean of 18 and 16 years respectively in the acute pancreatitis and recurrent acute pancreatitis subgroups. And this may be actually the most significant finding from this study, but only a small proportion of chronic pancreatitis participants, 16.3% to be exact, had neither personal history of smoking nor passive smoking exposure. So in chronic pancreatitis, some form of smoking exposure is highly prevalent. Now looking at pain in chronic pancreatitis, the highest proportion of patients with severe pain was found in current smokers at nearly 2/3 compared to half of patients with never smokers. And then the highest proportion of current smokers were found to have constant pain as compared to never smokers at 1/4 of those participants. And then lastly, in terms of complications of chronic pancreatitis, current smokers were more likely to have calcifications, pancreatic strictures, pancreatic stones, and atrophy, which all reaffirm findings of prior studies suggesting that current smokers have disease progression. And that is it. And I'm happy to take any questions at the end of the session. Thank you very much.
Thank you. So now I would like to invite Dr. Juliane Glaubitz from University Medicine Greifswald, talking on interleukin-6 that protects from systemic T-cell apoptosis in acute pancreatitis. Thank you.
Good morning, and thanks a lot for the opportunity to present our recent data here on this Congress. Well, today I would like to speak about the role of interleukin-6 during acute pancreatitis. It is well known that in acute pancreatitis, the premature activation of pancreatic proteases leads to an acinar cell necrosis, and the following inflammation is characterized by release of danger signals, the so-called DAMPs, as well as infiltration of macrophages and neutrophils into the damaged organ. We have a detailed look into the macrophage phenotype. Therefore, we co-incubated bone marrow-derived macrophages with freshly isolated acinar cells, as well as LPS as positive control. The transcriptome profile of the cytokines as fold change relative to untreated controls indicates a pro-inflammatory phenotype, and especially the gene expression of interleukin-6 was significantly upregulated. Also on protein level, we detected that under pancreatitis conditions, macrophages release interleukin-6. Interleukin-6 plays a central role in inflammation and cell survival, and we measured the serum cytokine concentrations of pancreatitis patients classified according to the Atlanta classification, and here we observed the disease severity increase. Interleukin-6 is already used as the disease severity marker of acute pancreatitis, but its role in the course of pancreatitis is quite unknown. What we also know is that during acute pancreatitis, we have a systemic T-cell activation. In 2 models of acute pancreatitis, so we have the mild model, the cerulean model, as well as the DAC ligation model, we characterize T cells according to their activation markers CD25 and CD69. And here we observe also an increase. Also here the question is how T cells are activating during the course of pancreatitis. And we postulate that the local immune response, mainly characterized by release of pro-inflammatory cytokines like interleukin-6, activates systematically T cells. To prove this hypothesis, we isolated T cells from untreated control animals, stimulated them with interleukin-6, and first of all checked the proliferation by measuring the Ki67 marker. And under stimulation with interleukin-6, we observed an increase in the T cell proliferation. To prove if this is really an interleukin-6 dependent effect, we used an animal model in which these animals' T cells cannot act or activated by interleukin-6. And in these isolated T cells, we could not observe any increase in the proliferation of T cells. What is also quite interesting is that we checked also the apoptosis of T cells. And here we see if we stimulate T cells with interleukin-6, this will protect T cells from apoptosis. So yes, interleukin-6 can affect T cells. With this knowledge, we then go into an animal model. Therefore, we used the animals in which interleukin-6 cannot activate T cells in a mild model, the cerulean model, and checked first the general interleukin-6 serum concentrations. And here we saw no difference in between the groups, and also the myeloperoxidase, this is a marker of the mobilization of immune cell, showed no difference. Then we had a detailed look into T cells, and here we observed then if interleukin-6 cannot bind on T cells, we have reduced number of T cells in general, as well as reduced proliferation of T cells. Also, we checked the activation marker CD69, and here we also observed reduced numbers. Quite interesting is that we also checked the apoptotic T cells, and here we have an increase of T cells. So also in our animal model, interleukin-6 influences systemic T cell response. For us, more important is also how these will affect the pancreatic disease severity. Therefore, we checked amylase and lipase levels and observed reduced levels in the serum, and also the pancreatic damage was reduced. In wild-type animals, we observed more edema as well as more infiltration of immune cells. Most leukocytes infiltrating the pancreas are macrophages. Therefore, we stained macrophages, CD68 positive macrophages, and could confirm our results. But here, this is quite interesting, is that not the infiltration is influenced, seen by CCR2 positive cells, more again the proliferation of macrophages in the pancreas. These results indicate that not only the local pancreatic damage influences systemic T cells, also the systemic T cells give a feedback loop to the local pancreatic damage. With this, I would like to conclude my talk. The pancreatic inflammation is mainly characterized by macrophages, which release interleukin-6. These interleukin-6 leads to a systemic proliferation and activation of T cells and give a feedback loop back to the local immune response. And as a take-home message for you, we can say that the local and the systemic immune response influence each other, and this is mainly interleukin-6 dependent. Finally, I would like to thank our lab and all the collaborators. Thank you.
Thank
Thank
you.
you.
Yeah, the next speaker is from Kong, Dr. Hong Kong, and he's come from Jiang Kong University Geomedical Center. Yeah, yeah, and this abstract also gained a Young Investigator Award.
Thank you for your kind introduction. It's truly an honor to present my research here today. First, I would like to disclose that I have no conflict of interest related to this study. Let's begin with a brief introduction. Post-ERCP pancreatitis is the most common complication of ERCP, with an overall incidence of 8%, rising to 15% with high-risk patients. A recent meta-analysis showed the incidence has remained unchanged over the past 50 years. While most cases are mild, with a low mortality rate of 0.2%, severe cases or related death can be devastating for both patient and physicians. Various strategies have been developed to prevent post-ERCP pancreatitis, with pancreatic stent being a key intervention, particularly for high-risk patients. It prevents pancreatic obstruction from biliary edema and ensures proper pancreatic drainage. Both the ASGE and ESGE recommend pancreatic stent placement for high-risk patients as they reduce the incidence and severity of pancreatitis. Also, recent studies suggest that combining pancreatic stent and rectal NSAIDs further enhances their effectiveness compared to rectal NSAID alone. So stent placement is relatively low risk and cost-effective, making them preferred choice for high-risk patients. But the optimal choice of pancreatic stent still remains debated, while factors like diameter, length, and flange design are all matters. But today I'll focus on stent diameter. Most studies compare 5 and 3 French stent with a meta-analysis showing 5 French is more effective for post-ERCP pancreatitis prevention. As a result, current guidelines prefer 5 French stent. But 4 French stent is another option we have. It has a smaller outer diameter than the 5 French stent, but maintains the same inner diameter, making it compatible with a 0.035 guide wire and offering comparable pancreatic drainage. Made from low-density polyethylene and ethylene vinyl acetate, it is softer and more flexible, potentially lowering the risk of pancreatic duct injury. However, no study has directly compared the 4 and 5 French stent for post-ERCP pancreatitis prevention. Therefore, we conducted a retrospective analysis to compare the efficacy of 4 and 5 stent pancreatic stent in preventing post-ERCP pancreatitis. Adult patients undergoing ERCP for biliary disease with difficult biliary cannulation were included. Exclusion criteria were ERCP for endoscopic papilectomy, ERCP for pancreatic disorders such as PD stone or stricture, pre-existing acute pancreatitis, prior pancreatic surgery, or PD stent was endoscopically removed within 14 days. Post-ERCP pancreatitis is defined using modified consensus criteria, and the severity of pancreatitis was assessed according to the revised Atlanta classification. Difficult biliary cannulation was defined based on the ESGE guideline as requiring more than 5 attempts, taking over 5 minutes, or involving more than one unintentional PD cannulation or opacification. The primary endpoint was the incidence of post-ERCP pancreatitis, and the secondary endpoint was the spontaneous stent dislodgement within 4 weeks. We conducted 1-to-1 propensity score matching based on variables like age, sex, history of acute pancreatitis, normal bilirubin levels, and high-risk procedural factors. Rectal NSAIDs were not used as they are unavailable in South Korea, unfortunately. Let's move on to the result. This slide summarizes the baseline characteristics of patient and procedures after propensity score matching. Of the 294 patients analyzed, 92 remained in each group post-matching. There were no significant differences in patient characteristics. However, stent characteristics were different. Most 4 French stents were 5 centimeters in length and single pigtail without internal flanges. But in the 5 French group, over half were 3 centimeters, and 17% of the 5 French stents were straight shape, and nearly 60% had internal flanges. Procedure-related characteristics were similar between the 2 groups, including procedure time, cannulation attempt, failure rate, and the use of high-risk techniques. The double guide wire technique was used in around 90% of cases in both groups. Transpancreatic sphincterotomy was more common in the 4 French group, but the difference was not significant. Pancreatic stent occlusion and pancreatic duct perforation were observed only in the 5 French group. However, the overall rate of adverse events were not different between the 2 groups. The incidence of post-ERCP pancreatitis was significantly higher in the 5 French group at 12% compared to 3.3% in 4 French group. Furthermore, all pancreatitis in the 4 French group were mild, whereas the 5 French group included 2 moderately severe pancreatitis. The multivariate analysis, which considered various factors associated with post-ERCP pancreatitis risk, found that the 4 French stent was an independent protective factor. This table shows the spontaneous stent dislodgement in the unmatched population. The 24-hour stent retention rate was similar in both groups at around 95%, although the 5 French group appeared to have a lower 1-month dislodgement rate. This was because flanged stents were more frequently used in this group. So stents without flanges showed a similar dislodgement rate of 93% in both groups. So in conclusion, the 0.035 wire compatible 4 French pancreatic stents may offer better PEP prevention and comparable 4-week dislodgement rate compared to the 5 French pancreatic stent. Thank you for your kind attention.
Thank you.
Thank you. Now we have a pre-recorded virtual presentation by Masayuki Ueno from Kurashiki Central Hospital on the theme long-term impact of acute pancreatitis on patients' quality of life, the final results of multicenter prospective study.
Good morning, everyone. Today, I'd like to present the final results of our multicenter study on the long-term impact of acute pancreatitis on patients' quality of life. We have no COI. The mortality rate of acute pancreatitis has decreased to less than 2% according to the latest Japanese nationwide survey. However, many patients continue to experience impairment in their QOL after acute pancreatitis. Several studies have demonstrated that severe acute pancreatitis negatively impacts QOL, but most of these studies did not include MAP or MSAT patients, and some studies only focused on post-pancreatitis QOL, not assessing the baseline QOL. Thus, we aim to investigate the longitudinal changes in QOL and the frequency of returning to work or daily activities after acute pancreatitis of varying severities. We also explored the predictors of QOL deterioration. This study, named LONG-TERM, was a multicenter prospective observational study conducted in Japan, supported by the JPS as a project study. We enrolled patients with acute pancreatitis of any severity, excluding those with a prior diagnosis of chronic pancreatitis. More details of the eligibility criteria are shown here. QOL assessments were conducted at admission 3 months and 12 months after onset. The SF12 questionnaire was used to assess 3 summary scores: physical, mental, and raw social component scores. Additionally, subjective perceptions of overall QOL and return to work status were evaluated. The primary endpoint was the physical component score, PCS, at 3 months. Secondary endpoints included in-hospital costs and readmission rates, but these will not be presented today due to time constraints. We enrolled 284 patients, and 234 patients underwent QOL assessments at 3 months. 25 patients who failed to receive QOL assessments at both 3 and 12 months were excluded from our analysis. This is a summary of patients' baseline characteristics. The median age was 67. The most frequent cause of pancreatitis was gallstone, and about 80% of cases were mild acute pancreatitis, according to the revised Atlanta criteria. The median duration of hospitalization was 10 days. ICU admission was required in 4%, and local complications developed in 50% of patients. The baseline QOL scores are summarized here. A score of 50 represents the average for the general Japanese population. In your cohort, the baseline PCS score was only 45 points. However, when adjusted for age, it appeared comparable to the general population scores. First, we compared the QOL scores at 3 months to the baseline values. Against our expectations, there were no significant differences between the baseline and 3-month scores. However, regarding patients' subjective perceptions, around 20% of patients felt that their QOL had worsened or slightly worsened, and they also experienced difficulties in returning to work or daily activities. Interestingly, QOL was improved in 70% of patients, which may explain why there were no significant differences in QOL scores overall. Then we compared the QOL scores between patients with and without overall QOL deterioration. As a result, patients with QOL worsening showed a significant decrease in physical component scores, suggesting that physical problems were the main cause of QOL worsening in these patients. Next, we explored the predictors for overall QOL deterioration at 3 months. In the univariate analysis, longer hospitalization and ICU admission were associated with a higher frequency of QOL worsening. In addition, the severity of acute pancreatitis was also associated with the frequency of QOL worsening. Next, we compared the QOL scores at 12 months to the baseline values. Here, a significant increase in mental component scores was noted. Regarding the subjective assessments, the results were similar to those at 3 months. Around 20% of patients experienced QOL worsening and difficulty in returning to work. In the comparison between patients with and without QOL worsening, the decrease in PCS was marginal, and a significant decrease in raw social component scores was found. Thus, raw social problems were considered the main reason for QOL deterioration at 12 months. Here is a Sankey diagram illustrating the relationship between QOL status at 3 months and 12 months. The proportions of each status were similar at 3 months and 12 months. However, it is notable that a considerable number of patients experienced changes in their QOL status between these 2 time points. In summary, around 20% of patients experienced impairment of their QOL and difficulties in returning to work or daily activities at both 3 and 12 months. QOL worsening at 3 months was associated with a significant decrease in physical scores. Long hospitalization, ICU admission, and the severity of pancreatitis were associated with a higher frequency of QOL worsening at 3 months. Therefore, in these high-risk patients, efforts to maintain physical activity during hospitalization and long-term support after discharge will be needed to prevent or minimize QOL worsening. Thank you very much for your kind attention. If you have any questions or comments, please feel free to contact me. Thank you.
Okay, thank you. So the next speaker is Dr. Rachel Hill from University of Kentucky, and he will talk about the serum biomarkers in chronic pancreatitis.
Hey, good morning, everyone. So my talk today is slightly changed from the original abstract, and that is because we have some additional data that we're going to be sharing with you. So I changed the title to Serum Bone Biomarkers in Pancreatitis, because what I'm going to be able to present to you is actually data that we have across the disease spectrum. And this is an exploratory pilot study from the NAPS2 cohort, which is the North American Pancreatitis Study number 2. Got it. All right. So to give you a little bit of background, pancreatitis is a progressive disease, and it starts often with single to multiple bouts of acute pancreatitis. And then there are a series of complications that are additive as the disease progresses, from potentially the development of diabetes, often to the addition of surgery, development of digestive problems such as steatorrhea. And what we wanted to know was, there is evidence that there is possible development of metabolic bone disease, and where could this development of osteopathy in these patients fall along this kind of mechanistic and progression of disease across time. So as we all know, that it is very important to maintain bone health as we age. In your mid-30s, you often will begin to slowly lose bone mass, and it is important just in normal life that we maintain very good bone health. And you can see in the figure on the right, there is an image of normal bone, and what happens as you develop metabolic bone disease and develop osteoporosis, that there is significant breakdown and deterioration of the structure of the bones. You get bone loss, osteoporosis, increased risk of fracture. There is also evidence that in chronic GI-related diseases that they're associated with inflammation, that these can disrupt the bone turnover balance. So within normal bones, there is this balance of release of cytokines and the balance of the production and resorption, or formation and resorption of bone by osteoblasts and osteoclasts. And there's numerous papers that have been published that have demonstrated in IBS, IBD, Crohn's, and other GI-related inflammatory diseases that there is an imbalance in the mechanisms and the activation of the osteoblasts and osteoclasts, and that balance is very disrupted. And so we call that kind of this state of imbalance. There is evidence in the pancreatitis field of bone health disruption. There are a significant amount of hip fractures just across the United States that have a significant healthcare cost associated with them. As I already mentioned, there are high-risk digestive diseases that put patients at an increased risk of fracture. And chronic pancreatitis patients in particular have a very high risk of developing significant bone loss. CP patients also have other additional environmental and metabolic risk factors. Many of them have issues with smoking, as we already heard Dr. Hahn speak to, vitamin D malabsorption, fat maldigestion. They often have issues with alcohol abuse, and all of these are additive risk factors that elevate their risk for development of metabolic bone disease. In a paper that was published about 10 years ago, there was some evidence that about 25 to 40% of CP patients have bone loss, either at a mild level with osteopenia or at the significant bone loss level where they develop osteoporosis. There is also evidence, 2 papers that our group has published, that there is increased prevalence of fracture in these CP patients. And here are 2 of those manuscripts. And basically what this told us was that there is some background evidence that these patients are at increased risk of bone loss, thereby increasing their risk of fracture. So again, here's some of the data from those previous papers. You can see that there is, as the patients age, there is increased risk of osteopenia and osteoporosis. But what's most important is if you look on the very left-hand side of that figure, that we have patients within 18 to 29-year age group. These are patients that normally should not be developing bone loss, and they are. There is also a significant proportion of these patients that are female, but also a very high proportion of males. So it is a pretty well-balanced risk for both males and females within this population. So for the study that I want to talk to you about today, we wanted to be able to get a better understanding of the molecular and metabolic mechanisms that are involved with the association of the progression of pancreatic disease, as well as the development of metabolic bone disease. So our hypothesis was that changes in serum biomarkers would be affiliated with bone remodeling and could be altered in the patient samples that had both recurrent acute pancreatitis and chronic pancreatitis. And we were comparing those to our control patients. And our first aim was to first identify bone turnover markers in the serum of patients with CP compared to control. We wanted to see, okay, just on the extremes, do we see a difference? And then secondly, if we add in that recurrent acute group in the middle, can we see that as patients progress across this disease continuum, do we see differences? So as I said, these were samples from the NAPS2 consortium. This was a very large cohort of patients that had over 1,600 patients. There were 540 in CP, of which we randomly got 40 samples out of the CP group. Out of 460 that were in the recurrent acute, we got 40 of those samples. And then out of the 695 controls, we got 30 of those and tested all of those on an exploratory custom bone biomarker panel that we designed. And then we did statistical analysis on the data. So just to give you a little bit of an idea of what these bone biomarkers are, we had 3 that are markers for bone resorption. And they can either stimulate or inhibit the mechanism, thereby causing bone resorption. There are also several markers for bone formation. And again, those can either be inhibitory or stimulatory in their action. And then there were several markers of bone turnover or regulators. So here's our kind of standard table 1. And I just wanted to point out here that this is important for us because one of our next steps will be to look at subgroup analysis and really dig in a little bit deeper into some of the significant findings that we see here and how those are relating to the bone turnover markers. So for increasing disease severity with bone resorption, we have sclerostin, DKK1, and rank ligand. And the most important ones here are sclerostin with an AUC of 0.97 is fantastic results. And we see a significant increase with disease progression, as well as just control versus CP and RAP versus CP. For rank ligand, we see a very similar trend. The AUC for rank ligand is not as fantastic as sclerostin, but it was still pretty high at a 0.82. for increasing disease severity with bone formation, we looked at osteoprotegrin, insulin, and leptin, and then with some slight significance there. And then for the changes in just the general bone turnover markers, the one I want to highlight here is osteopontin. And like sclerostin, we saw that there was significant changes both at the extremes with control versus CP and RAP versus CP. And the AUC here is a 0.93. So in conclusion, we see that changes in serum biomarkers are affiliated with bone remodeling and are altered in patient samples with recurrent acute pancreatitis and chronic pancreatitis compared to controls, and that systemic molecular and metabolic mechanisms are actively involved in the development of metabolic bone disease. So for next steps, as already mentioned, we have some subgroup analysis that we are working on with our statisticians, and we want to also validate these bone marker results using the PROCEED study patient samples. So with that, I'd like to acknowledge our contributors and collaborators and all of the work in the background. Thank you very much, and I'll take questions at the end.
Thank you.
Thank you. Our next speaker is Ioannis Patoulakis from University of Minnesota, and will talk about the impact of 30-day readmission among patients with necrotizing pancreatitis on mortality, morbidity, and healthcare resource utilization. Welcome, Patoulakis.
Hi, everyone. Thank you very much for this opportunity. Acute pancreatitis remains a leading cause of gastrointestinal hospitalizations in the United States. And in general, hospital readmissions continue to pose a significant challenge in healthcare systems. Particularly for necrotizing pancreatitis, we notice significantly higher readmission rates from reported rates of 20% to up to 75% from different studies, compared to mild cases of acute pancreatitis, which is expected given the severity and complications. Hospital readmission rates in general are utilized a lot as a quality metric in healthcare systems, and the information related to that is important to study in order to evaluate the quality of treatment during the initial hospital stay, but also the ways for improvement. Particularly high readmission rates lead to worse patient outcomes and pose a significant strain in healthcare resources. The aim of this project is to determine the 30-day readmission rate in necrotizing acute pancreatitis, to evaluate the impact on healthcare resource utilization, but also to evaluate potential risk factors of readmission in acute necrotizing pancreatitis. For the purpose of this study, we're utilizing the National Readmission Database. Briefly, it is the largest public database for hospital readmissions in the United States, with 30 participating states so far. It's developed by the Healthcare Cost and Utilization Project, which is a family of databases and tools, and it's sponsored by the AHRQ organization, which is a government agency. Its purpose is to track patients who are readmitted after an initial admission and to evaluate their frequency of readmission, but also potential risk factors that lead to that, but also to address the impact of those readmissions, both on healthcare costs, but also on patient outcomes. It contains data such as diagnosis through ICD-10 codes, procedures, again through ICD-10 codes, certain patient demographics, but also certain hospital characteristics. Particularly, this study is a retrospective cohort study utilizing the National Readmission Database data from 2016 up to 2020, basically from the beginning of ICD-10 codes. A readmission is defined as the first admission to any hospital for a non-trauma diagnosis within 30 days of discharge. And as a primary diagnosis code, we utilize the ICD-10 codes for acute necrotizing pancreatitis. The primary outcome of this study was to determine the all-cause 30-day readmission rate in acute necrotizing pancreatitis, and some secondary outcomes include the in-hospital mortality rate and readmission mortality rate, the most common causes for readmission, morbidity, but also resource utilization for both the initial admission and readmission. We found a total of 214,000 index admissions with acute necrotizing pancreatitis through this database. Of those, 202,000 patients were discharged alive, and of those, 88,925 patients were readmitted. Briefly going through our cohort, the mean age of our patients was 51 years old, female gender, 35% of the patients. We saw a pretty even distribution among different insurance providers, and the median income of the patients included. The patients were mainly admitted in large hospitals, metropolitan teaching hospitals, and the patients mainly reside in large metropolitan areas. Going through the results, we found that patients with acute necrotizing pancreatitis had a mortality rate of 3.8% during their index admission, an average length of stay of 13.4 days, an average cost for their hospitalization of $40,000, with average charges by the hospital of $182,000. In regards to the readmission of these patients initially diagnosed with acute necrotizing pancreatitis, we found that the readmission rate was 44%. The mortality rate during the readmission was actually even higher at 4.6%. The average length of stay was very similar, 13.8 days, and the costs and charges were also very similar compared to the index admission, further signifying the burden of a readmission, both on patient outcomes and healthcare costs. The overall burden, $3.6 billion for hospitalization costs, and this is just acute necrotizing pancreatitis. Total charges of $14.9 billion, and a combined length of stay of 1,235,000 days. Now, going through the 5 most common causes of readmission in acute necrotizing pancreatitis. Just to clarify something, these are ICD-10 codes. So not surprisingly, the most common reason for a readmission is pretty generic. It's just the diagnosis of acute pancreatitis with uninfected necrosis unspecified. Going through the other 4 reasons, we see, again, not surprisingly, the top 2 common reasons being alcohol and biliary. But the interesting thing is that the alcohol etiology is almost 3 times more common than biliary, 17% versus 6.8%, which is again not surprising to see alcohol-induced pancreatitis lead to more readmission in necrotizing pancreatitis. The third most common etiology was found to be sepsis at 13.7%. Again, not surprising. We know that sepsis causes worse outcomes, more severity, more likely to cause organ failure as well in acute pancreatitis. And the 5th most common etiology, surprisingly, or maybe not surprisingly, at only a 4% of the readmissions was found to be infected necrosis. Lastly, we run a multivariate regression analysis utilizing and including all the parameters that were found to be statistically significant in a univariate analysis. Those parameters were on a patient level, hospital level, treatment level, but also related to severity. Going briefly through those, I highlighted some of the statistically significant parameters. Again, we are looking at potential risk factors that lead to readmissions in acute necrotizing pancreatitis. So based on these findings, we found that younger age, insurance providers, including Medicare or private insurance, disposition other than home, led to more likely readmissions in acute necrotizing pancreatitis. Some other findings, some other risk factors: admission at a large hospital, admission at a teaching hospital. And lastly, some events/procedures that happened during the index admission, patients that had sepsis, patients with acute respiratory failure, patients that required percutaneous drainage, patients that required total parenteral nutrition, TPN, patients that required endoscopic ultrasound for any purpose. All of these patient groups were more likely to be readmitted. Necrosectomy had the opposite effect, with patients undergoing necrosectomy being less likely to be readmitted, actually. There are several limitations related to utilizing the National Readmission Database. It doesn't allow to track patients readmitted at a hospital in a different state. So state tracking is one. We could only track patients readmitted through the same calendar year as the index admission. We don't have certain clinical information such as labs, imaging studies, medications. We don't have certain information on social factors. I would say the biggest limitation is using ICD-10 codes, administrative coding, which comes with coding errors and inconsistencies. And lastly, we also didn't have any access to outpatient data, which can be very important when analyzing readmissions. To summarize, we found that the readmission rate in acute necrotizing pancreatitis was 44% based on the National Readmission Database. We found significant economic burden, high costs and charges both during the index admission and readmission. The length of stay was found to be very similar between the index and readmission at 13 days. Alcoholic, much more frequent, much more likely to lead to biliary to lead to a readmission in necrotizing pancreatitis. Only 4% of the readmissions were attributed to infected necrosis, although 13.5% were attributed to sepsis. Lastly, some potential risk factors leading to readmission in acute necrotizing pancreatitis included younger age, disposition other than home, admission at a large or teaching hospital, and some index admission complications such as sepsis, acute respiratory failure, or some procedures such as percutaneous drainage, use of endoscopic ultrasound, or need for TPN. Necrosectomy had the opposite effect, led to fewer readmissions. These are my references for this presentation. Thank you for your attention.
Thank you.
Thank you.
Yes. Congrats on the Young Investigator Award as well.
So the last presenter is Jiale Wang. He's come from Mayo Clinic. He will introduce a mouse model of hemorrhagic necrotizing acute pancreatitis.
Okay, so good morning, everyone. Thank you for the kind introduction. And it's a great honor to present our work here. And I will be discussing how the accumulation of digestive enzymes in pancreatic ducts triggers the hemorrhagic necrotizing pancreatitis. So before we move to the data that I have, I would like to introduce our mouse model, which was published in 2022. Basically, we generate two mouse models using a human bacterial artificial chromosome that expresses human PRCS1, PRCS2. One of these models harbored the R122H mutation and referred to as HP mice. When crossed to a homozygous state, the mice show spontaneous pancreatitis. But heterozygous HP mice do not develop spontaneous pancreatitis. And for the heterozygous HP mice, we found that they are highly sensitive to a single dose of cerulean injection compared to wild-type PRCS1-PRCS2 mice. And out of curiosity, we explored another secretor called bombesin, which also activates trypsinogen. And we wanted to see its effect on our HP mice. And as expected, 8-hourly intraperitoneal injections of high-dose cerulean caused more severe edematous pancreatitis in HP mice compared to B6 mice. And interestingly, bombesin caused hemorrhage in HP mice. However, in B6 mice, it doesn't cause pancreatitis. Well, pancreatic edema and serum amylase levels were similarly elevated in both cerulean and bombesin groups. the hemorrhagic phenotype with bombesin was striking and confirmed through histology. And before we discuss in the histological features of the bombesin-induced model, let me briefly show a typical cerulean-induced pancreatitis model in our HP mice. As we know, the cerulean model is characterized by scattered necrosis, inflammatory cell infiltration, and a vacuole formation, as the arrows indicated. And in contrast, the bombesin-induced hemorrhagic pancreatitis in HP mice show a lot of red blood cells in the parenchymal, and the impaired blood vessel integrity, eyelid injury, and thrombosis, and 2 different patterns of acinar cell necrosis. Some lobules show widespread necrosis with significant inflammatory cell infiltration, while some other lobules show necrosis but without any inflammatory cells, likely due to the secondary ischemic injury. So to better characterize the injured blood vessels, we performed immunostaining for alpha SMA and CD31 in the cerulean group. Blood vessel integrity was intact. However, in the bombesin group, the vessels were clearly damaged as indicated by these arrows. So next, we ask whether bombesin-induced hemorrhagic necrotizing pancreatitis will progress to chronic pancreatitis. And over a 7-day observation, we found that similar to cerulean, bombesin-induced pancreatitis rapidly progressed to chronic pancreatitis. And when comparing the longer-term outcomes of the cerulean and bombesin models, we found that the cerulean treated mice still have a lot of acini, likely due to the regeneration. And in contrast, the bombesin treated mice show extensively cyst formation and significant loss of acinar cells. We further measure the body weight change, as we can tell from figure B. The bombesin group mice lose the body weight at around 6 to 7 grams, and compared to 1 to 2 grams in the cerulean group. And more strikingly, almost 50% of the mice from bombesin group were dying. We then wondered whether this bombesin-induced hemorrhagic phenotype was specific to the R122H mutation. And to investigate, we performed cerulean and bombesin injections in Y-type human PRCS1-PRCS2 mice. And surprisingly, this hemorrhagic phenotype was not mutation specific. And however, the severity of hemorrhage correlated with trypsin levels, and patterns of edema, serum amylase, and body weight changes, and survival were similar to those observed in HP mice. So to understand why this happens, we turn into in vitro studies. We isolate the acinar cells from HP mice. We compare the dose response curve for CCK and bombesin. Unlike the CCK-induced biophysical pattern, the bombesin group was slightly biophasic. This was because of F-actin redistribution, as we can see from the morphology differences in cerulean and bombesin treated acini, and using ethylium bromide to evaluate the membrane integrity, and we found that the bombesin treated acini did not show cell membrane injury when soybean trypsin inhibitor was present in this system, and unlike the cerulean treated ones. So another rationale coming from Dr. Fred Gorelick's studies. Dr. Fred revealed that the bombesin activated trypsinogen and facilitate its secretion into the duodenum without causing pancreatitis. And however, when the pancreatic duct is ligated, the bombesin causes endematous pancreatitis. And this leads us to hypothesize that the bombesin-induced hemorrhage may be the pancreatic ductal pathway. Then we look back to those histology and found that the bombesin caused significant duct dilation and protein plugging and impaired duct integrity, as we can tell from these arrows. Even for 7 days, the bombesin group still has a lot of protein plug and dead cell debris. So in contrast, the cerulean group duct is empty. So since this unique phenotype induced by bombesin was likely due to the pancreatic ductal pathway, we thought that trypsin should be in the duct in the early times, and that could be a direct evidence. So we injected cerulean and bombesin and sacrificed the mice 30 minutes after the last injection. And by 4.5 hours, the hemorrhage was evident in the bombesin group. And we performed the immunohistochemistry for trypsin. And interesting, there's a lot of brown staining in the duct, and which was absent in the cerulean group. And if we look at it carefully, the brown staining was even, in the lining of pancreatic duct. Therefore, if we are right about the mechanism of bombesin-induced hemorrhage, we expect the low-dose cerulean would have similar effects. And yes, it is. When we give the mice with single injection of different doses of cerulean, we found that low-dose cerulean caused hemorrhagic necrotizing pancreatitis in HP mice, just like the bombesin. Okay, so to summarize this study, we draw the working model. Basically, the high dose of cerulean caused trypsinogen activation, but the active trypsin is being retained in the acinar cells and cause edematous pancreatitis. But however, the high dose of bombesin and low dose of cerulean cause trypsinogen activation, but also cause the trypsin secretion into the duct and damage the duct and then cause the hemorrhagic necrotizing pancreatitis. And finally, I would like to acknowledge all the lab members and collaborators' help, and thank you for your attention.
Thank you.
Thank you.
So now it's time for the presenters to reconvene at the podium, and I would like to invite the audiences for questions.
Well, while you're coming up, Suhail Hussain from Stanford, thank you very much for these provocative talks. I had two questions. I'll keep them brief. One is for Dr. Cooley. This is a fascinating concept of palagenesis. And I guess the question is, how is that different from acinar to ductal metaplastic formation? Is it similar? Are there differences? And then the second question, if I might just state it, and then is for Dr. Turkis, is so MRI versus MRCP, is there value in just doing both? Is there complementary information? Is there increased accuracy if you combine the two versus ditch one for the other? And so, end there.
Can I answer the second question first? That's a great question. I will talk about this at 11:30. We actually combined MRI findings and MRCP findings and generated a score. The MRI and MRCP findings are complementary in a way that when you combine them, it better correlates with the histopathologic triad of chronic pancreatitis, which is one, acinar cell loss. Second is development of fibrosis. And the third is ductal dilatation. So it provides a better, higher AUC, which I will talk at 11:30. Thank you for the question. It was a great one.
Okay, you can hear me now. Okay, thank you very much for your question. So in this case, palagenosis encompasses from start to finish. So you take the mature cell, you run it through the cycle, and it redifferentiates. And that requires this metaplasia, acinar to ductal metaplasia, to occur during that process. But it would be interesting to know whether this is a transient part of palagenosis, that metaplasia. It'd be interesting to know if they are more or less ductal, I guess, compared to ADM that persists, and leads to disease. But so it does encompass that process.
Thank you.
Thank you.
About MRI, sir, it was a nice talk where we got it. The parenchyma is most important as compared to the duct in MRCP and MRI. So there is a very thin line in the recurrent acute pancreatitis and early chronic pancreatitis. So we have a Roseman criteria for US where there is a lot of inter-observer variability. So do you feel with some scoring system, which you are mentioning, you are presenting in 1130, will replace the Roseman criteria and identify an early chronic, which is the most important things to know?
Did you ask me to replace?
Replace, yes.
I'm not qualified to make that statement. What I'm trying to do is just to do the job that the radiologist did not do for the past 40 years. Gastroenterologist came up with a criteria using ERCP 40 years ago, and radiologist just adopted it and has used for 40 years. But nobody has did a multi-institutional prospective study on MRI of parenchyma until DDK opened a consortium about chronic pancreatitis, and I was lucky enough to join it. So inter-observer variability with the MRI parenchymal findings can be from 0.87 to 0.72, which is higher than Cambridge. It's probably higher than EUS too. So it is very promising. That's all I can tell you for now.
Thank you. Please.
Lee from Stanford. I have a question for Dr. Rachel here. She's here. Or can I ask to Dr. Conwell instead?
Sure.
So that's very interesting finding. And also, I'm interested in that project. Actually, the poster we just presented with the work with MySum, using the pediatric CP cohort, we also found bone markers, including rancor and OPG. So I'm wondering, there's some, clearly there's evidence of the bone marker and then CP. My question is those cohorts you guys used for this presentation, whether there's those circulating markers that has correlation with the DEXA scan bone mineral density? That's right.
Yeah, that's a very good question. So this is those are the NAPS2 serum patients, and there's no DEXA scans in NAPS2. So the great opportunity that we have is with PROCEED, we have like over 300 DEXA scans in our patients. And obviously something's going on when you look at very young patients with chronic pancreatitis with abnormal DEXA scans in the osteopathy paper that Phil led. So we're very, very excited about that because mechanistically is where we need to go. So these bone markers may give us some idea of the imbalance between osteoclast and osteoblast activity. And rank ligand and osteopontin has been described also previously in IBD and other bone demineralization diseases. So we know some of the mechanisms. So it's very exciting to look at that. But the next step is to look at the PROCEED data where we have the DEXA scans.
Okay, thank you.
Yes.
Thank you. Please, we alternate. So please.
Jamoni from Shanghai General Hospital, China, and also trained in Stanford. I have two small questions for Dr. Kang from Korea. In your study, I think the length of the pancreatic duct stent varies from 3 centimeters to 7 centimeters. And did you ever perform a subgroup analysis of different lengths of the stents and how would it impact the overall outcome? I think this is an important point because this is also a limitation of the 2024 Lancet study you have cited in your lecture. And another question is about the migration rate of the stent. Besides the dislodgement rate of the stent, did you ever assess the other types of migration rate, such as the stent shifting within the pancreatic duct? Thank you.
Yeah, thank you for the good questions. First thing was you mean the subgroup analysis of the stent lengths, right? Yes. So as I presented, the 4 French group is almost the patients used the 5 centimeter, And the other group is a little bit mixed from the 3 centimeter to the 7 centimeter. So so we compared only the 5 centimeter between both groups, but the number of the 5 French group used 5 centimeter is very small, so small. So we did comparison, but there's no differences, but the subgroup is so small, so you can tell which length is better in this study. I think this is a limitation for our study. But in some studies that the longer stent might be prone to occur the post-ERC pancreatitis. They have a more chance to injure the pancreatic duct. So the 4 French stents have a more longer stent than 5 French stents, but they show the lower rate of post-ERC pancreatitis. So I don't know, but that might be my answer. And the second question is, you mean, can I get
just please keep it short because we have still some.
Sorry, I can tell you later.
Yeah. Thank you, please.
I'll be quick. Andrea Gais, Boston University. I have a question for Dr. Wang, and probably I missed it, but did you try this series of low-dose cerulin or bombizine injections in your model, which only has the PRSS1 transgene and the mutation? Or and what happened?
Yeah, we tried. So the bombizine also cause hemorrhage in that mice which only express PRSS1 122H without PRSS2.
So it's not an expression
It's
dependent thing.
but the severity was less severe than the one with PRSS2.
Okay.
Yeah. So it is correlated with trypsin level and the activity.
Okay.
Yeah.
Thank you.
Thank you, please.
Hello, this is Junfeng from Chongqing General Hospital. I have a small question for Teno from Professor Teno from NIH, and you have raised a consideration of MRI characteristics in chronic pancreatitis. But have you considered that you could raise the radiomics to research the pancreatitis of MRI? So you just use the T1 scores, but have you considered other ways like radiomics? Yes, like 3D slicer, this software.
Great question. Thank you for that. That work is currently ongoing. Yes, we are going to look into the AI of that also. And also my next aim about the radiomics or the AI is to make these parametric scores automatically calculated using AI so that the radiologist will not say, I don't have time for this.
Okay.
So if you use a tool, then they will be able to measure, and then the score will show up on your screen. So yes, we are working on it. Keep following us.
Okay, thank you.
Thank you. Thank you for your patience.
Thank you. Two questions, two different presenters, one to Dr. Wang, and it's more of a comment. One thing to consider is in your model where you have the mutant that you have increased trypsin levels and background macrophage activation. So it'd be worthwhile in the basal state to look at the activity of the M1 type of macrophages. The second issue is that there's bombizine will activate macrophages, whereas cerulin will not, and that may have something to do with the difference, some of the differences in the severity and the pattern of the phenotype. And so what we talked about, you may want to check with Dr. Jensen and see if there's a receptor inhibitor for the bombizine receptor on the macrophages that's not on Astner cells.
Okay, thank you. That's a good point.
More of a comment. And for Michelle, do you have any, I don't remember from your work, is the regulation of D52 levels when they fall, is that mediated by at the mRNA level or by degradation?
So during pancreatitis, D52 undergoes autophagic degradation by protein. I don't know if we've looked at mRNA, but I can tell you for sure the protein goes down in lysosomes.
And do you, relative to the question about, I think Soheil's question, and ADM. If you look at ADM, if you will, in chronic pancreatitis, those changes, do D52 levels stay down in those cells?
That's a great question. We haven't looked at D52 in chronic pancreatitis, but that would be a good thing to analyze.
Okay, thank you.
Thank you very much. We are absolutely to the minute. Thank you. Thank you to all the presenters. Hui Ho. Thank you, and hopefully this, until we meet again, will happen soon. So I just want to invite all the speakers to take one picture together. Thank you, everyone.